Hi, Imad. Imad.
Hello, sir. How are you?
I am very well, Imad. How are you?
I'm good, sir.
I tell Salman that Imad is your backbone, is your spine. समझा ना? No, you are doing very good work, and because of you, I think so much coordination in websites and webinars and all those things that you are doing is just wonderful. I wish, Imad, why don't you come to Mumbai with me?
Sir, I will.
No, enjoy and do good work. Okay, Imad? And let's begin quickly, Imad.
Thank you very much, sir.
Sandeep Vaishya is also there.
So, Dr. Musbais.
Hey, hello everybody. Hi, Dr. Goel.
Hi, Sandeep.
So, Imad, is the presenter going to present? You said that the first case will be presented by the presenter himself.
Sir, but he's not here, so I think you have to present.
Okay, then I will present this case, though it is a pretty sketchy case. Some things are missing. So let me just share my slide. Can you see my slides?
Yes.
Okay. So this case is sent by Dr. Besson and Dr. Thomas for RMSH Neurosurgery, Kimberley, South Africa. Now, this patient is a 30-year-old male. 30-year-old male with no comorbidities, no allergies or surgical history. He was stabbed in the neck, zone 2, 10 days prior to presenting with any neurology. Initially, he presented only with dysphagia and neck pain, and CT and X-ray shows no fractures, but a hypopharyngeal injury. So there were no neurological fallout or complaints on the initial presentation. He was managed conservatively by surgery and ENT department. He presented 10 days later with acute onset quadriplegia. He actually awoke quadriplegic with urinary incontinence. He reports worsening of neck pain and dysphagia for past week. He was seen in emergency. Vitals were within normal limits. His sensory and motor level was C3, and he had flaccid paralysis with absent bulbocavernous reflex. His blood tests were, CBC was normal, mildly raised CRP, and it was suggested of localized early systemic infection. So they presented with this radiology. I'm presuming this was a barium meal, and so you can see some leakage of the dye there. And so there is the CT scan which shows some epidural, some prevertebral collection. And if you see in the MRI, there is this collection here in front of the cord. And so there's a retropharyngeal abscess along which has spread to the epidural space anteriorly. So he has a compressive myelopathy. There is significant cord edema from C2 to 3, 4, 5, 6, nearly T2, from C2 to T2. Here, the MRIs show the acute myelitis and patient presented with quadriplegia. So now the question is, what would you do? Will you treat with antibiotics, corticosteroid, surgery, and then what? So I'll start with you, Mirza. What do you think about this case?
Oh, can you hear me?
Yeah.
Okay. Hi, Sandeep, Professor Goel. Nice to meet you. Hello, everyone. This is a very tricky case. I guess it has a retropharyngeal abscess, as it says here. And this collection would be, this is like an MRI, which is made just like 1-2 hours after the stabbing, right?
No. I think this MRI was done 10 days later when the patient presented with quadriplegia.
Okay, 10 days later. So are there any information? What did they do initially with him, or he just came to the doctor after 10 days?
So, no, he came initially. He was seen by surgery department and ENT department. He had a pharyngeal injury, and he was managed conservatively.
Okay.
He had no neurology at that time. So this neurology was 10 days later, sudden onset. Let me see how many days later. 10 days later.
Okay. I think I would do I would do it from both sides, from here, so from ventrally and from dorsally.
No. Before going to surgery, do you think anything should have been done at the time of initial presentation? Like, was something missed because patient presented with acute onset quadriplegia 10 days later? And initial CT scan and X-rays were normal, but was there anything else that could have been done so that we could have avoided this catastrophe?
Well, what we do in Marburg always is that if you have a stab wound in the neck, the guy gets an endoscopy and he gets a check by the ETN. It doesn't matter, you know, there are some injuries of esophagus or injuries of pharynx and structures like that, which are not very easy to be seen in CTs. So I think in my practice, if I would see someone who has a stab injury to the neck, I would definitely get him examined by ETN. Maybe this small injury of retropharyngeal space or of esophagus could have been seen if we had done an endoscopic inspection. No, it's tricky, but I think that's maybe something which could have prevented it, because I'm guessing that he had an injury of these structures at the initial moment, and then he developed an abscess in 10 days.
Unfortunately, the slide deck doesn't mention what was done, except for the fact that he was managed conservatively. We don't know whether any endoscopy was done or not. What antibiotics were given, nothing is mentioned. So, Dr. Goel, what do you think? What would you do?
Whatever was the situation at that time, the issue is this guy has come now quadriplegic.
Mm-hmm.
You are seeing quite a significant abscess right in front of the cord. Although the abscess is not so big to cause complete quadriplegia, I will say he would have, with this kind of abscess, he might at best develop some weakness or quadriparesis. But now that he has developed quadriplegia, there is no time to waste, no time to think. Abscess is there, we have to drain it. And we have to drain it widely, urgently, and immediately as an emergency kind of a procedure. As the abscess is going more on one side, you might just like to go from one side. I will not come from anterior, I will like to go from posterior. I will go do a laminectomy, maybe more on one side, drain the abscess, then go above and down and drain the abscess, and if necessary, go on the other side and drain the abscess. Drainage of the abscess is the #1 treatment for any kind of abscess. And it might just happen that you drain the abscess and he recovers. Means there is no other option at this point of time. Now, where the abscess is coming from, whether there is something from the esophagus, whether there is something from the retropharyngeal area, whether some aerodigestive tracts have been damaged, that can be taken care of later. What we have to do now is emergency, urgent, quickly, immediately open the patient, drain the abscess widely from whatever route suits you. I don't think you should come and do any kind of anterior operation for this at this point of time. You need to drain it from behind. Wide laminectomy, urgent drainage, that is the treatment. Then when we get the pus, we look for antibiotics we have to need to give according to the growth that will happen. So that will be the protocol in my view. Sandeep.
Mirza, what do you think? What would you?
I think we would do 360 number here. We would probably go from posterior, maybe as the first in a stage surgery, as the first moment to do a wide laminectomy and to try to drain it from behind. And I think I would definitely do an inspection from ventrally with somebody from the ENT team, because if it probably has some open place in pharynx or in esophagus, and I think that needs to be treated also very acutely in order to prevent to get the patient infected and septic. And I think that of course, as Professor Goel said, to put the pus out, to put the abscess out is #1 thing if you want to treat this kind of patient. But I think as long as you have the reason for abscess, that would be an opening in the esophagus or opening in pharynx due to the knife. I think the patient does not have a perspective to get better very soon. So I think I would do I think that in the 2, 3, 4, 5, 6, between the fifth and the sixth cervical vertebra, I think that disc is also it might have been damaged, or this is only edema of the surrounding vertebrae. I think I would go in with ETN. I would let them take care of esophagus or retropharynx or whatever, and I think I would at least take one disc out and also try to get the abscess from epidural space from ventrally, just to get a decompression from both sides. That would be my opinion.
Do you think that by just doing one level disc, would you get enough space to remove the pus?
I think that's very much important. It depends on how does the pus look like when you do it from the dorsally. That's why my first intention would be to do a laminectomy in several levels. And there are different kinds of abscesses. Sometimes you have a very liquid abscess, a situation where it just spurs out, and sometimes it is very stiff and hard. So I think that would be maybe dependent on the posterior surgery and what we get from that.
So you have yourself answered my question. If it is a very liquid abscess, then you can simply drain it from behind alone, right?
Yes.
But if it is thick abscess, then just by doing a discectomy, I don't think you will be able to take out much.
Yeah,
right?
Then you would have to do
you may end up doing a corpectomy.
Yeah, at least 2 levels, then or a corpectomy. But I think it's very important to inspect him ventrally because of this injury.
Yeah, but if you, in that infected space where the infection is so severe that it has caused quadriplegia, would you like to do a corpectomy, place an implant there in that situation?
No, not a corpectomy.
So what is the role of going anteriorly?
I think that his initial problem and the reason why he has an abscess is ventrally.
The only time, if at all, they had to repair that wound was when the injury was fresh, right? At that time, when they decided to manage it conservatively, after 10 days, when there is severe infection, no ENT surgeon or GI surgeon is going to attempt to close that wound. Most likely, they will do a peg and leave a drain there just to let the pus out. So I don't think there is any point in going in the spine anteriorly in that grossly infected space. Perhaps I agree with Dr. Goel that first we just do dorsally, decompress whatever we can, probably give him high-dose steroids, and then let the ENT guys or GI guys manage the wound anteriorly, and then perhaps do a peg also. What do you think, Dr. Goel?
See, most important thing is to remove the abscess urgently.
Yep.
That is the immediate necessity, and remove the abscess widely. See, from anterior, unless you do 2 or 3 level corpectomy, you may not be able to see the entire extent of the abscess. It may be just liquid pus, then it is all right. But if it is a little bit solid here and there, and also if you see the axial image, it is not like well-defined pus. It is a kind of a irregular kind of material. So my take will be, come from behind. He's already quadriplegic. Drain the abscess widely. If necessary, extend the laminectomy. This is a smallish little operation. It is not a huge operation, And once we have drained the abscess, the emergency is over. There is no emergency now once the pus is released. Then we find out where the leak is coming, where the infection is coming from, what is the story, is there any damage to the esophagus, is there some leak is coming from there. Then that is a second kind of story, which we can do at leisure. But what he needs is, a quadriplegic patient needs is immediate. Now, take him to the theater, remove the pus, and then treat the other things. Those are hypothetical. What is seen, that should be treated. What is not seen can be observed and can be seen later. That is my take, my dear Sandeep.
Yeah. So are there any questions from the audience, or would anybody want to manage it differently? Well, so I think if there are no questions from anybody, I think we all agree on the management of this case. We can go to the second case. And I will request Dr. Goyal to present the second case.
So I have to present the case, Sandeep?
Yeah, and then we can discuss that.
Okay, let me see if I can do it. I'm not sure. Yeah. You can see the slide?
Yes.
Okay, so this is the case, and it has been sent by Dr. T.K. Naidu from Kimberley Hospital. So this is a case of a 23-year-old lady who was seen in orthopedic department for chronic low back ache. And they found out that there is L1 vertebral collapse and they suspected TB. And they did a CT guided biopsy, CT scan guided biopsy. And the histology was giant cell spinal tumor. So this was the histology, giant cell spine tumor. So they discussed about the need for operation and all those things, but the patient did not agree for operation and defaulted and went away. So this was in 23 Feb, and then the patient came in August 23. So about 6 months later, the patient came when she had increased symptoms, but no neurological deficit still. So there was no neurological deficit then, but there was a slight giddiness, maybe some pain here and there or whatever. And this patient did not agree for an operation. And then they came second time after 6 months. So this is the story. So this was the scan in February. Actually, this scan shows better. Just see this image. So this is the February image, February 23rd, 23. And now here, you see this tumor has grown. This was the earlier tumor. This tumor has grown and involved the vertebral body and all those things, and you see a paraspinal tissues and quite aggressively increased in size from Feb to January. So in about 1 year, the tumor has increased, and the histology that they got was giant cell tumor. So this is the story. And let us see what the opinion of the House is regarding this case of giant cell tumor with such a large increase in size in 1 year, no definite worsening of neurological deficits. Symptoms have worsened, and the patient is now set for treatment. So what is the opinion?
Do you have a SAG image to see the vertical extent of the tumor?
Yeah, so this is the SAG image.
Okay.
I'm not sure the time here. Is it just a minute? This is Feb. This is smallish tumor, Feb. Okay.
Yeah.
And here the tumor has increased quite remarkably from here to here. The disc space is gone, and the disc was gone then also. There was some tumor behind the disc space. This tumor here, which is smallish here, and now it has increased in size. Okay, Sandeep, your take on this?
Yeah, so these tumors are pretty notorious, and they are challenging to remove, and they come back very fast if you don't remove them completely. But in such extensive tumors, again, it becomes very challenging to remove them completely, particularly when anteriorly they would be involving the venous systems and the aorta sometimes. You can see them pushed out. So ultimately, I don't think we have too many options. We will have to go 360 degrees. We have to radically try to remove the disease from back and then front. For the front, I think I will take help of GI surgeon along with me, and then do a radical removal, put in a cage, and then fix him from behind again. So it has to be a pretty big surgery. And they bleed a lot. So I will also do an angiogram beforehand, and if possible, if there is any embolizable vessel, then I would like to embolize it before I do the surgery.
Yes, my dear Mirza, what is your take? You are muted, Mirza.
Sorry, I agree with Sandeep. I would still try to remove it completely. I think that makes sense to go anteriorly with the general surgeons to get the corpus of L1 and L2. So corpectomy L1-2 implant, we will do probably expandable cage and posterior decompression and stabilization. I think only to put a cage is not enough. He will probably need a stabilization T11-12 to L2-3 because I think that the cage itself, only cage, will probably not do the trick.
L3, 4, I think, mean because L2 we are already removing.
5, 4, 3. I think that L2 and 1 need to go both out.
Yeah, so fixation
then-
will be 3, 4. Yeah.
Yeah, fixation would be 3, 4. Yeah, 3, 4. T11-12 to L3, 4.
But would you embolize it before operating?
Yes. They bleed as hell. Yes.
Another issue in this, I was just wondering, because this is a giant cell tumor. These are locally aggressive. Actually, histologically, they are not very malignant tumor. They are almost benign tumors. Histologically benign, locally aggressive, and locally destructive tumors. Giant cell tumors. And metastasis also can be seen of these tumors here and there, which are quite frequent in such rapid growth of tumor. Now, in this, there is I'm not sure because I'm not an oncologist, but denosumab, this monoclonal antibody treatment, is quite effective in this particular clinical entity. And I think one has to take in cognizance of this modern treatment, which is quite effective. I'm not sure, tell you the truth, I don't know much about it, but I've just heard that this treatment is good and this may be effective. I'm not sure. Is there any other expert here on the panel?
Yeah, so
Sandeep?
we have given denosumab to some of our patients, and we have had mixed results. And generally speaking, we have given them post-operatively just to prevent recurrences. So we don't have any long-term follow-up data. I don't think we have tried it in any patient to just reduce the bulk of the tumor. Yeah, but as you said, that patient doesn't have any neurology, so that might be a good idea to give a couple of cycles of denosumab, see the response. If it shrinks, fine. If it doesn't, then we go ahead with surgery.
Other thing is, if you do radical tumor resection, complete resection, you may avoid any kind of adjuvant treatment. I'm not sure what is the role of adjuvant radiation treatment, any other treatment in this clinical entity. But considering that this tumor has grown quite rapidly and quite aggressively, I think we will have to consider, multimodal treatment. Yes, Mirza, what you were saying?
We in Marburg just have a similar case, but we had it in a localization T2-3. So T2-3 with a very big extension to the front behind the heart, very hard completely to resect. It was maybe 95% resection, incomplete resection. Of course, it came back and as an expandable implant. So I'm also not an oncologist, but I don't even think that there is like a very official protocol to this because it's a rare tumor. But what we did this first time, we did the resection or corpectomy, implant stabilization, and then afterwards radiation therapy. And then when the progression started, then again surgery, and then denosumab. So denosumab as a second line chemo when the recurrence occurs. That's how I have it in my experience, but as a very rare tumor, I did not see a lot of them.
Yeah, but we give denosumab right from beginning just after surgery. I had a pretty bad experience with one young guy who presented with left upper limb weakness, and he had a large disease at T1 and a little bit at T2. So we did a T1, T2 corpectomy. His brachial plexus lower trunks were getting involved. So we removed the disease radically, definitely not 100%, but maybe say, as you said, 90%. And guy was fine, his power improved. 1 month later, he presented with hemiplegia. And then when we investigated him, he had massive disease all over the lungs, all over brachial plexus, supraclavicular, had spread right up to the axilla. and I think he died within few weeks. So sometimes they can be extremely malignant in their behavior. So, but what kind of radiation would you give here?
The patients in Marburg received particle therapy. I think it were the protons, and it's, I think, a protocol which is similar to Hordoma's. I really don't know the details, but it was a particle therapy. We have a proton center, and
you may have a proton center, but there are very few proton centers in the world. So
yes,
if you
yes, I know.
center, what would you do then?
I think then standard radiotherapy 54 gray for a metastasis, which is used in a bone metastasis.
I don't think that would work very well. The thing is, people have used hypofractionated stereotactic radiosurgery, spine radiosurgery very effectively in such patients. And it works much better than typical 30 fractions IMRT.
So you think like a targeted stereotactic radiosurgery?
Yes.
For
maybe
the remnant?
Depending upon the extent of the disease after surgery, maybe 3 to 5 fractions, but that works beautifully well.
See, as you rightly said, Dr. Mirza said, like chordomas. You see, these tumors are behaviorally like chordomas. Even chordomas are locally aggressive tumors. Chordomas are also not histologically quite aggressive. Similarly, giant cell tumors are also not histologically aggressive, but locally quite aggressive. You can get metastasis in giant cell tumors, metastasis in chordomas. So behaviorally, I think these two tumors are quite similar. Because proton beam works in chordoma, I'm not sure whether it works here, but I have a feeling now the standard protocol of treatment in this case that can be recommended is first go for radical tumor resection. That is one. Second thing is stabilize the patient solidly. That is number two. And then refer the patient to the appropriate person who can go further from that point. And that should be the protocol of treatment.
Agreed.
Okay, Sandeep, some noise is coming in between.
I think Mirza's colleagues are chatting. Because when I mute Mirza, this sound goes.
Okay, I think I'll try to make it better. Sorry.
So, any questions from the audience?
Yes, Apurv, you want to ask?
Well, I want to just say one thing, that it is lucky that this disease is at L1 level predominantly, which is an easier level to operate. If this was at S1 or S2 level, we would have had to sacrifice multiple nerves and bladder bubble would have gone in that case. So this is a relatively easier place to operate.
Yeah. So should we go to the third case, Sandeep?
Yeah, I think so.
Okay.
So you can stop share. Mirza, you can present the third case.
So, okay. So this is the case from Dr. Prasad. I see he's also here in our chat. Consultant neurosurgeon from Bhatia Hospital Research Center in Mumbai in India. So we have a 48 years old female, BMI 28.4. She's typist by profession. She has no comorbidities. She has progressive stiffness in all 4 limbs, paresthesia in palms and soles since 8 months. And she has difficulty in getting up from bed and changing position, imbalance on walking, weak grip in both hands, slow speed of walking since 3 months, occasional urinary urgency, no relief with over-the-counter medication. She has an MRI of cervical spine, which we will see with extensive core T2 signal, differential diagnosis edema or myelopathy from C3 to C5 levels with disc osteophyte complexes at C3, 4 and C4, 5. She was operated for 2-level ACDF, C3, 4 and C4, 5. She worsened all symptoms after surgery. and she had urinary incontinence, constipation, excessive spasticity, inability to walk, weight gain of 20 kilos over 2 months due to steroids. And following the surgery, she has an Ashford grade 3 spasticity in all 4 limbs, plantar bilaterally extensor, power in all limbs, MRC grade 3 out of 5, significantly poorer grip in both hands, all reflexes MRC 3+, sustained plantar clonus. She has pain, temperature, and fine touch, which is impaired in both legs, impaired posterior column sensation, and severe truncal ataxia, so that she is unfortunately not able to stand. And this is the radiological imaging. So on the left side, we see the index MRI, the initial MRI. And on the right side, we see the post-op X-ray. And on the next slide, we see MRI following the first surgery and the CT following the first surgery. So there are 3 questions for the board. Was the first surgery appropriate? How long should the waiting period after first surgery be before deciding a repeat intervention? And what is the plan of management now? So I will just quickly show the images. This is the index MRI and post-op X-ray. Professor Goel, would you like to comment on this first?
You know what, let Sandeep, because this Dr. Prasad is from my own department.
Okay.
So I will like Sandeep to discuss.
So
And
did you do this first surgery or it was done somewhere
no,
else?
this first surgery was not done by us. This first surgery was done elsewhere, somewhere else.
Because even if you had done this, I'm sorry to say that I don't agree with the approach of this surgery. If you see, there is significant cord edema right from lower border of C2 to upper border of C7. And the compression is at multi-level. So just by doing 2-level discectomy, I don't think you are going to achieve much. Apart from that, if you see the implant, the screw seems to be penetrating the posterior cortex and going into the canal. Though I don't think that is contributing to any issue here. But I would have done it posteriorly, multi-level laminectomy and lateral mass fixation. And or maybe if somebody wants to do a laminoplasty, I generally prefer to do laminectomy and lateral mass. So that is my first question. What would I do if the patient was presented to me? Now, the second question, what was the second question?
The second question was, if you get a patient like this, and now you have to take care of
How
his
long will you
problems,
wait?
what would you do? What would be the waiting period?
I don't think if the patient worsened after surgery, I don't think there is any point in waiting. One should have gone in immediately posteriorly and try to release the compression, because if you see, the compression is still there. And so I would, and whatever compression is there, the penetrating screws would also be adding to that. So if you release it posteriorly, the cord can move back and perhaps that compression can reduce. So I would not wait and I will do it immediately. And now the third question was, now when the patient is presented to me, I would still do the same and I'll go posteriorly.
Do you think that this screw, which we see now in the axial view, the screw of the cage, did it do any additional injury? Would you take that out or remove it in any way or revise it from ventrally?
See, the way I see it is you have to go posteriorly anyway, right? I don't personally feel that it would have pierced the dura and damaged the cord. I think it would just be compressing over it. So what I'll do is I'll go posteriorly, decompress it, fix it. After that, I can repeat the MRI and see if the screw, if the cord is getting compressed by the screw at all or not. I don't think it would, because the cord would have migrated back. But if at all it is, in that case, I will go ahead and remove it. Otherwise, not.
So you know what, Sandeep, as you have heard me on several occasions, on several platforms, that my concept in these cases is that it is multi-segmental instability that is the issue, and identification of the unstable segments and stabilizing is the main crux of the entire treatment. As you rightly said, that the instability is extending above and below, and these 2 levels are not sufficient enough. and more levels should have been included in the fixation construct, or not decompression construct. Now, Dr. Apurva is here. Apurva, you want to show what you did and what was the result? I will show you, he will show you what was the, if he can.
Yeah, I will stop sharing my screen and maybe the Dr. Prasad can show it.
Yes, yes.
Okay.
Hello, good evening, everyone. I'll just put my slide for the post-operative X-ray, which has been done recently. Yeah, so this is the post-operative X-ray.
Show the preoperative condition of the patient. Preoperative condition of the patient.
This I don't have it correctly, sir. Quadriplegic and unable to move out of the bed. I have this post-operative video of the patient at a span of 6.
Oh. Some problem with your computer. So essentially what was done here is there was no further decompression, no removal of the screws, as Mirza was suggesting, probably to remove the screw which is going inside. So there was no need, we did not do anything, just stabilizing by lateral Camel's technique, no midline decompression, no laminoplasty. And this patient improved dramatically in the immediate postoperative period from a very, very bad neurological condition to quite a happy situation within few days of surgery. This was how many days after surgery? I don't
He
think.
said 6 months.
6 months? I think less
No,
than
it was 6 weeks, sir. It was 6 weeks.
6
6
weeks.
weeks after surgery. So there is a dramatic improvement. So this concept of instability being the major issue, now I am trying to work on that for a long period of time, maybe for 10, 12 years with multiple articles on the subject, that instability is the key issue in degenerative spine. Stabilization is the key issue in degenerative spine. Osteophyte formation, reduction in the disc volume, reduction in the canal size, cord edema, they are secondary to vertical spinal instability. So that is the concept on which we are working now, and we are working in a very massive manner. And I will invite the panelists and other people who are listening that from August 2nd to 6th, we are conducting a live surgery show in Mumbai. And it will be my great honor and great pleasure to have all of you, whoever wants, they will be my guest, and we will sponsor everything locally, whatever we can. But you please come to see this, as I frequently say, revolution in spine surgery. And please come and enjoy this revolution. Mirza, you are most welcome, okay?
Thank you. Thank you, Professor Goel. So if I've understood correctly, you would not do any kind of decompression, you will just stabilize it?
Yes. So, if we know that in spine surgery, compression is the issue and decompression is the treatment for all spinal problems. My answer to that question is compression is not the issue and decompression is not the treatment. Instability is the issue and stabilization is the treatment. So with that concept, I'm working. I hope I'm sure you must have heard me on some forum, my presentation on the subject. But even if you have not heard, I'm giving you an opportunity to be here in Mumbai, 2nd to 6th August.
Thank you. Thank you. Very kind.
Yeah, that was a fantastic case, and you made your case by showing this case. I've heard you several times on several occasions about the same topic. But still, mortals like us, like I particularly, will not dare to leave it without decompression. Anyway, we are going to still fix it. But I would prefer to decompress also, because then you are going to rapidly remove the compression.
See now, you know
We
what
got
this
lucky in this case. In some cases, there may not be any because it may take time, and by the time the neurology is permanent.
this
So
concept of decompression is an old concept. This concept that decompression and fixation is also not such a new concept. It is an old concept. So I am saying, which is different. I am saying that decompression is not necessary. As you have heard me several times. As you have heard me several times, the clinical recovery is magic, like you have seen in this patient. And now I have got hundreds of patients to show where clinical recovery is such magical. So this concept that decompression is not the issue and stabilization is the treatment is a new thing. Decompression is old. Decompression and stabilization is old. What I'm saying is no need for decompression. So this is a different concept, different way of thought process, and has to be worked up, has to be taken in a different perspective. I'm not saying that this should be accepted radically and immediately. One has to think about, and I am giving an opportunity for people to come because we are doing live surgical demonstration of several cases during this workshop. And I hope, and I have done on several occasions such workshops, not only in India, but in several other countries where we have showcased this kind of philosophy. And I hope that you will be able to, of course, Sandeep has to come, there is no question. But
no, I'm coming, but I'll be coming for 3rd and 4th, that is Saturday, Sunday. So I hope you are doing the surgery on those days.
2nd and 3rd, I'm doing for sure.
So yeah, I'll be coming on 3rd and we'll be leaving 4th evening. So
Okay, see one day you can see. Okay.
perfect.
So let's go to the 4th case now, and I will have
No,
to.
I don't think there is a 4th case. So is there a 4th case? I think there were 3 cases. We wrap
I
it up
also
here.
think there were 3 cases.
Yeah.
Yes, we are doing 3 cases.
So let's wrap it up. I think we had a pretty good discussion and they were nice cases. So I thank you all. Good night.
Good night. Good night.
Thanks, everyone.